All right, hello and welcome everyone. My name is Jean Pulvermacher and I'm the co-director at the Great Lakes Addiction Technology Transfer Center. And I am happy to welcome you to our webinar today, Understanding and Make a Difference for Pregnant and Parenting Women with Substance Use Disorders. Again, please put your name and where you're from in the chat at the screen, and you can message Emily or Zach on the tech team and they can help you out, and we're being recorded. So today our training is presented by the Great Lakes Addiction Technology Transfer Center. We are located at UW-Madison and we serve Health and Human Services Region 5. So that includes Minnesota, Wisconsin, Illinois, Indiana, Michigan, and Ohio. Today's training is sponsored by SAMHSA. The Great Lakes ATTC is funded by the Substance Abuse and Mental Health Service Administration under cooperative agreement, Great Lakes ATTC, that you can see below there. At the ATTCs, we do believe in language matters, words have power, and people first. We use affirming language to promote the promise of recovery by advancing evidence-based and culturally informed practices. Here's just a little map of the 10 regional ATTC centers across the country. Again, they each match up with the Health and Human Services region, and I did put a little star by the Great Lakes region here that we're at UW-Madison. And here's just a picture of downtown Madison, UW. You can see the Capitol in the middle. Just a shout out to our city, Madison, in between the two lakes, Mendota and Monona. Again, we are located at UW-Madison. The areas of emphasis for the Great Lakes ATTC include addressing the opioid epidemic, medication-assisted treatment, recovery-oriented systems of care, and process improvement in behavioral health. And you can visit us on the website www.attcnetwork.org/Great Lakes. How to access our services. We do provide training, technical assistance, and webinars. And you can go to that webpage and you can click on our upcoming offerings if you look at our training and events calendar. You can also connect with us. We do very robust social media, so you can join our mailing list. You can subscribe to our e-newsletter, and you can also follow us on Twitter at Great Lakes ATTC. And we are going to be doing understanding and making a difference for pregnant and parenting women with substance use disorders today. We're doing this webinar today. It's also going to be a repeat on June 30th. So if something happens, you can always check us out then. And today's presenters are Tara Fisher, Pat Tucker, and Deb Warner. They are from Advocates for Human Potential, and you're going to have a wonderful time with them today. They're experts in the field, and I'm very excited to share their information with you today. And with that, I think I will hand it over to them. So thank you.
Great. Thank you so much. Let me just do a quick sound check with you. Can everybody hear me okay? It sounds like the answer is yes. And I want to also say happy, I don't know if happy is the right word, but I want to acknowledge and celebrate Juneteenth Day today. And I think that this webinar is actually a really nice way to acknowledge Juneteenth Day, because it shows how far some things have come and recognition. And then we also have so many opportunities to continue to help women with substance use disorders and their children to continue to grow. So happy Juneteenth Day to everyone, and thank you for joining us today for this session. I will also say that I am using a new slide clicker, and I'm always a little bit curious when I'm doing some new technology, how well it works, and it does not seem to be working, Emily. There we go. I don't know if you did that or I did that, but you've already met who we are, so we can go to the next slide. And I think, Emily, you're going to need to do that for us, because I think that you're the one who's moving it, or it's moving very slowly.
Sounds good. I'll move it for you, Deb.
So I want to start with us actually doing a chatterfall, and everybody has gotten pretty well acquainted with Zoom. You can go ahead and move to the next slide. But what I'm going to ask everybody to do is to put a comment responding to this question: what word describes how you feel when you see a pregnant woman with a beer in her hand? And you can go ahead and put it into the chat box, but go ahead and wait a couple moments. We'll go ahead and just send them out and see all of the answers that we have. We have a lot of sad, disappointed, worried, concerned, terrified, anxious, empathy, uncomfortable. Excellent. Horrified. And the reason why we do this is because, we feel this way, and the people in the communities feel this way. She feels this way. And that's a lot of burden. This is a topic that has a lot of emotion to it. Many of us have been personally affected. We know people who have experienced substance use disorders, and we bring that emotion with us in our interactions with people. So thinking about how we pay attention to our emotions and how they can drive us towards positive or could drive us towards negative responses to people, and then how that person who is struggling feels when they're responded to with some of these emotions. So I wanted to start us off with that kind of percolation as we're moving forward. And go ahead and go to the next slide. And our agenda for today, I'm going to spend a few minutes kind of reflecting on the field and how far we've come in terms of PPW services. So I called it an introduction and reflection. Then Tara is going to talk to you in terms of, Pat is going to talk to you in terms of making a difference, really focusing in on engagement and how you can reach and engage PPW women, because you can't make a difference with them if you're not reaching them and involving them in recovery. Then we're going to turn to Tara. She's going to talk about some of the evidence-based practices specifically for pregnant and parenting women and with substance use disorders, and paying attention to the kinds of services that we want to be trying to deliver. I'm going to come back and talk about family-centered services, so expanding not just to the pregnant woman, but also expanding out to her children and other family members and what that looks like. And then Pat will talk about recovery supports. And if we have time at the end, we'll come together and we'll do a little bit of a panel with questions and discussion. Feel free to also actively use the chat box. We have too many people to have everybody on video for right now, but feel free to put your comments, your questions into that chat box, and we'll use that also as a way of building the conversation. So this is what we have scheduled for today. Go ahead and go to the next slide. So now is my opportunity to do some of my reflecting and kind of setting the context. And I should also warn you that I could spend a week and a half talking about making a difference for pregnant and parenting women with substance use disorders, and we'd still have more to cover. So we've really tried to highlight some of the key, most essential elements. And as I was thinking about doing this and reflecting, because I think it's just a time of reflection right now also, I was remembering when I started working in this field, when I was 4, most of our services were really based on men's services. There weren't very many women's services, and we were starting to get gender-specific services developed. And those gender-specific services were basically the same as the men's programs, but only for women. And we found that they didn't work very well. So through time, we started to shift that to 30 years ago, when we started to evolve gender responsive services specifically for women. We started to talk about trauma and the relevance of trauma, using a more of a relational approach in terms of priorities, having examples and experiences that women could relate to, but we still could not find services for pregnant women. So I remember being on a phone trying to find a program that would take a pregnant woman, and nobody was willing to take her because of the liability issues, or they didn't know what to do. And so that really says, that isn't really that long ago, how far we've come, right? But we're still on our way. So we started to build the gender responsive services. There a lot of energy. Many of you have been experts that have been involved with that, participated, and we started to recognize as a field that women with substance use disorders have different risks, consequences, treatment and recovery needs, and gender responsive services started to be born and recognized. So and delivered also. And many of your programs, there's a lot of some of those hallmark programs in the Great Lakes region. Go ahead and go to the next slide. And then particularly in the 90s through the early 2000s, I was thinking it was the 80s, but actually as I look back, it was really mostly in the 90s. There was a significant effort to really recognize and acknowledge the importance of addressing pregnant, postpartum, or in parenting women. And you'll hear also that when I say PPW, I usually say pregnant and parenting women, because the needs don't disappear like after the baby is born, but we also refer to PPW as pregnant postpartum women. But so some of the things we saw is there was a women set aside for the substance abuse block grant that was shifted to be, it was increased and shifted to really a focus on PPW services, with a lot of requirements that people address the specific needs of pregnant women. We expanded research and produced a number of different articles around what those services should look like, developed collaborations. SAMHSA created publications and also created the couple of different funding programs that really created a lot of comprehensive services, programs such as MetaHouse and Wayside that I know are both in your region, that were really comprehensive boutiques of services for pregnant and parenting women. And we continue to further recognize the needs of women, including pregnant and parenting women. And I also want to stop for a minute, because while all of that is true and we were building that knowledge, most women, including pregnant women who were seeking services, did not get access to those services. They instead were in more of a generic substance use outpatient treatment program that was coeducational and did not necessarily all the way address these things. So go ahead and go to the next slide, just kind of trying to bring us up in terms of where our knowledge came. This slide has a definition of gender responsive services for women from Stephanie Covington. And I'm just going to read it, and you'll see that there's still a lot of value in it, and it's also in some ways dated. So it's the creation of an environment through site selection, staff selection, program development, and program content and materials that reflect an understanding of the realities of women and girls' lives, and that addresses and responds to their challenges and strengths. And I really like that comprehensive approach that pays attention not just to being trauma informed or being relational, but pays attention sort of to the organizational system. Or if you look at some of what we've done around trauma informed care, around building sanctuary, where I think it's also interesting though, is it leads with creating an environment. And now I think our services are shifting away from, we have an individual tower or silo or house that is our substance use disorder services for pregnant women. And then sometimes we have other service systems that we're interfacing with, but everything is really centered there into much more of an integrated environment. And I'll talk a little bit more about that in a moment. I just want to finish kind of with this definition of gender responsive services, because of course we can't talk about, pregnant and parenting women are a subset of women in general. And we do want to be able to provide across the needs of women, not just serving pregnant and parenting women. So it does include being trauma-informed, person-centered, comprehensive, culturally relevant, relational, as well as building connections. And I often will include in there, but it's up in that other definition, really addressing strengths and self-efficacy, as well as family-centered, which is part of relational. So thinking about that as an overall context for gender responsive services. And yes, Jennifer, I love Stephanie and the work that she's done, and some excellent resources as well. Go ahead and go to the next slide. So in that same period, we did a lot of work, and really SAMHSA evolved a model, the CSA Comprehensive Model for women and their children. And you'll see on this, because this was done in the early 2000s, that the language has actually changed. We didn't talk about recovery support then, we talked about community support. But part of what I really love about this model is it talks about creating a basket and thinking about the different services as a ring basket, as individual rings in a basket. And if you just have one ring and you try to hold something or hold a family in it, just falls right through, right? So it's really the building everything together that helps hold and nurture a family as they're moving forward. And I think that's a nice analogy when we're thinking about the types of services that we have and how we're offering sanctuary for the PPW women who we're aiming to help. It talks about both, it uses some different language than we use today, but clinical treatment, clinical support, and community support types of services, which is pretty much similar to what we talk for both women and children, starting to recognize the value and the need for children to access services as well. And then the ideas, the handles, which also go throughout, are cultural competence, gender competence, and developmentally appropriate. So in terms of thinking about that basket throughout our presentation today, I want you to keep thinking about the rings of the basket, and are we offering a basket to really help and support women? Go ahead and go to the next slide. And this slide, this is from something that we developed also in that same time period. Part of what we found is that when we talked about family services, everybody had a different meaning. And so we built a continuum to help people think about moving to progressively higher levels or more comprehensive levels of addressing the needs of families. So, 0 is no family focus at all. They hopefully at least are addressing family as part of a woman's treatment or recovery plan, but there's no emphasis on family. Services for individuals with family involvement, programs for women with childcare, because again, we didn't really know as we were developing services how much of a need, infant mental health was not something on people's radar screen. So there was really this idea of if we just let women bring their children with them, that the children will be fine, and then the women can concentrate on building their own recovery. Now, of course, what we found is that the children needed more than just childcare oftentimes, and that we needed to build more comprehensive women and children services. The other piece, my friend Kathy Eisenhower is always talking about, we created a Sophie's Choice situation where women were expected to choose between which of their children they were going to bring with them to services and how challenging that can be. Into family services, and then family-based treatment services is kind of those comprehensive pieces together. So this model was developed. It's not so actively used, but it shows kind of that different, when we're talking about working with pregnant and parenting women, trying to consistently move up in terms of our types of services. And go ahead and go to the next slide. So this framework for family-centered medication-assisted treatment is developed in 2019. And you'll see that there's a pretty significant shift. Instead of talking about the types of services, or when I'm working with other service agencies, one of the things that they would say is, what's in that black box called treatment? And really trying to hone in on what the services we're trying to deliver to families and women are. This really focuses on all of the different kind of collaborative agencies. You'll see that shift towards integration in terms of how this is focused. So you have criminal justice, MAT and SUD services, physical health, mental health, parenting, child development, child welfare, and support services. And that goes kind of across pre-pregnancy. So before people are talking about being pregnant, the pregnancy and prenatal period, the specific things, because a lot shifts right at birth, and then the postnatal period services for infants, parents, and families. So this shows the shift to a model that's more of an integrated model. And I think that that's kind of where we've come, is we went from gender specific to gender responsive to integrated care, where we still want to be able to keep some of those features of being gender responsive at the same time. But it starts to look really different. Go ahead and go to the next slide and be ready to shift it, because I'm not going to spend a lot of time talking about this, but part of what has driven that and part of the opportunities which have been afforded to us as it relates to that expanding the integration are significant shifts in child welfare, criminal justice, and healthcare. So in terms of child welfare, we have now, well, I'll just go to the last one, the Families First Prevention Services Act, which creates funding opportunities, allows for residential services for families, because the focus isn't just on a plan of safe care for services for the child, but also for the family as part of the plans of safe care. Easier, earlier interventions. In criminal justice, it's sort of interesting because we really have had a lot of focus around decriminalization, increasing recognition of the public health needs, but not necessarily true for pregnant women. There are still continues to be legislation around criminalizing substance use during pregnancy. So paying attention to that. And now the significant calls for reforms and increases of services available for people involved with the criminal justice system creates a further opportunity to think about that integration and the need to really be able to help support women in effective ways. And then in healthcare, the increase in access through the Affordable Care Act, recognition of behavioral health, social determinants of health, and health disparities. So, people now have learned, I think everybody on this call knows infant mortality is higher among African-American babies in the first year of life than it is for most other populations. I think it's also high among Native American populations. But what research has recently done is taken a look at if that baby has an African-American pediatrician, then the rate the rate is comparable to other populations. So what does that mean in terms of our health disparities and taking a look at it, thinking about the social determinants of health, what Pat's talked about in terms of housing and how we pay attention to those. And we'll come back to all of these things. The expert in health and OBGYN and other settings to help get people aware and intervene early. And the significant expansion of MAT and provider involvement in SUD services. And Emily, I'm just going to ask you to reset the timer for 4 minutes, if that's possible. And go ahead and go to the next slide. So then we also have significant changes in our substance use delivery system and how we address pregnant women and infants, especially as it relates to the opioid epidemic, but we're also seeing it in terms of perinatal mood disorders and building more of a comprehensive system. I will just say right now, although Tara will talk about it later, is MAT has been accepted and acknowledged by the American Academy of Pediatrics, the American College of Obstetrics and Gynecology as the best course of treatment for pregnant women with opiate use disorders. And then in terms of diversity, equity, and inclusion, there's increased recognition of gender fluidity and the needs of non-binary populations and LGBTQIA+ women. And that does include parenting, LGBTQIA women. And also, when we're thinking about how we manage and we continue to provide gender responsive environments, we also want to be inclusive of people who identify themselves as female and who society may identify as female both. So having that welcoming environment. Continuing to address structural racism and health inequities and population health, particularly related to women, I think are two of the other trends that are really having profound impacts on PPW services. And go ahead and go to the next slide. So again, this all sets that tone for what those integrated services look like and how we manage to have those baskets made of those comprehensive resources that will help women with substance use disorders and their families in this integrated environment. So these are just two people who, I am consistently reminded of. One of them actually was in the flyer for this session, is part of the reason why it's so important for us to be making a difference. So Giselle at 4 months pregnant, says something like, what they don't understand is that I don't stop because I can't stop. I do care, but I don't need lectures. So if you go back to thinking about the woman with the beer and all of those emotions that we were feeling. So what she's saying, and early interventions, brief interventions, some education are certainly important. Most women who are using opioids, stimulants, benzodiazepines in alcohol in later stages of pregnancy, usually it's because they can't stop. It's not that they're choosing it, it's that they have a substance use problem and they haven't been able to access the kind of help that they need. So thinking about Giselle as we move forward and how we help her, and then Charlisa, these are not their real names, who is from Fresno. And one of the things that she said to me that just captured some of the problems in our system. They took my baby and now he has a home and people to love him. I have nothing. And at the time she was experiencing homelessness. She felt completely alone. She had no resources and no sense of why she should continue trying to live. So we want to reach and give hope to the Giselles and Charlisas. And go ahead and go to the next slide. Also build then that sense of recovery and resilience for women and families as we're moving forward. So that sets the kind of stage. I'm going to now turn it over to Pat, and Pat's going to talk about engagement, and then we'll keep on moving forward from there. Thank you.
Well, hi, everybody. Good morning. We're going to talk about engaging pregnant and parenting women with SUDs. Next slide, please. Engaging. I mean, we all know you have to work on the relationship. But we also know that we have to work to build that rapport and that trust with women. It just doesn't happen by itself. We need to take an active role in that, making sure that the woman feels comfortable and, sometimes not pushing until she's comfortable, picking up on clues. Here's another one that I think we need to do a better job at. And when I say we, I'm speaking about me, building self-efficacy right from the start. We need to help women identify the things that they're good at so that they can have some power in this relationship and they can also work on things. I think one of the worst things we can do is to have a woman who has skills and capabilities, and we're doing everything for her without teaching her how to do it and helping her do some of the work to get her involvement. Next slide, please. So engagement, I'm talking to you, but I know you all know what engagement is. But we need to make sure we're paying attention to it. So it's the process of working effectively. That word effectively is important. Joining with an individual to set shared goals by establishing a relationship of respectful curiosity about individual and family strengths and needs. When I first got into working in the field, um, and I've been in the field. I don't know if you can see my gray hair, but I've been in the field for quite a while, and I've earned every one of these gray hairs. But I always felt like and this is gonna age me. Columbo. I don't know if anybody remembers Columbo. Um, he was a detective, and he kind of was bumbling, but he asked lots of questions. And when I'm working with a new person, I feel like Columbo. Like I want to get to know that person. And it doesn't always happen with me and a piece of paper. It happens with me talking to that person and asking questions out of curiosity, but also just wanting to know this person who's in front of me. Next slide, please. So, when you're pregnant, um, most times what I've experienced, and I think in the field we've experienced, is pregnant women are often more motivated because they're no longer just thinking about themselves. They're thinking about they have another being. So that's a time that they're feeling like, okay, I need to do something. I may need to make some changes. It's not just about me anymore. Um, if engagement and treatment, can lead to a reduction or abstinence, which promotes better health outcomes. So if we can engage the pregnant women in treatment, um, we're gonna have better results. They're gonna do better. Um, we need to make sure we're linking to comprehensive health. It's hard to just deal with one part of a person because we are not built like that. We are not compartmentalized. We're all together. So if my mental health is not doing well, it's going to affect everything else about what I'm doing. So we have to make sure we're doing comprehensive care. Um, and I'm all about informed decision making and making sure that the women I work with have an active role in their care. And so one of the things we have to do is we have to educate. We can't just assume that the woman knows all of her options. We have to put out the options objectively and let the woman look at the options and make some decisions. Next slide. There's a lot of fear and anxiety related to the children, feeling like they could lose their children. That's stressful. That is, you know, and I know some women who have lost their children and gotten pregnant again and said, this time I am going to make it work. I'm going to keep this child. And that's a good starting point for us. That's a good, she's got a goal. We're going to get working on that and try to help her reach that goal. There's also, concern about the health of the baby. Will I have a healthy baby? Um, Also, just can I be a good parent? And that is not just for pregnant women using substances. That's for all moms, wanting that assurance that I'm going to be a good parent. So I can't imagine what it would be like if you add substance use to that picture. Of course, you're going to be concerned about your parenting skills. You're struggling with yourself, and now you will have another person to also take care of. Next slide, please. There are obstacles. And this is just part of a list. But again, as Deb was talking about the history, what it led me to think about was we've come a long way, but we still have a long way to go. And so even though we've come to a point that, there are places for women to get treatment, there's still stigma. There's still a lot of women that are nervous about going to get treatment for fear of the stigma, for fear of, you know, everybody's going to know I'm walking into that door, everybody's going to know my business. Everybody's gonna know something. We also need to make sure our we're providing a culturally congruent programming to people, to women. Um, and we also, need to remind ourselves to also look out for abuse, any type of history of abuse that can play a role in trying to engage a woman. Um, I used to work with quite a few women who I realized after a while something else was going on. And so doing a little bit more asking of questions, being a little bit more curious, come to find out they were in an abusive relationship. And that was playing a role in the engagement piece. They weren't able to fully engage because they weren't sure they were going to be allowed to keep coming back. So just wanted to throw that out there. So just, don't assume if somebody doesn't show up that they don't want to show up. They may want to show up, they may just not be able to for other reasons. Next slide, please. So I I'm excited because this is it. I am going for a record here, and this is going to be on participation. So I want 100% participation. I'm going for it today. I'm going to set the record. So I know you all know about stages of change, right? You got that, right? You know it. So I want you on this list. You see the ruler on here? When I read one, I want you to write in the chat box a number where you think she is on the stages of change. So please help me. I want 100%. Come on, people. All right. So Lizzie, who is 4 months pregnant, says that she went out with her boyfriend last night and they both used black tar. 1 week ago, Lizzie stated her goals were to keep custody of her 6-year-old daughter and be a good parent. Where on the stages of change is Lizzie? All right, I'm seeing numbers coming through. Keep them coming. Everybody, I'm going for it. So I'm seeing 4s, 3s, 2s, 5s, 3 to 4, 7, 3 to 5, 7s, 2s, 6s, 5s. Wow, this is amazing. I might actually make my record. You guys are awesome. 5s, 3, 4s. Okay, so I think and I it really depends on how you look at it, but I can see making an argument for a 3, but I can also see making an argument for a 7. So my argument for a 3 is she stated those goals, but she went out and used, but we all know that sometimes what recovery is not a straight line, right? So maybe she just relapsed or had a bad day yesterday. So I would put her somewhere around the 5 to 6 mark. So I think you all are on target with your numbers, and that's awesome. Okay, we're gonna do it one more time to prove that it wasn't a fluke. All right, so Jackie is 6 months pregnant with her 4th child. She does not have custody of her other children. Jackie's goal is to keep custody of the baby. She states that she knows that she should stop taking TNT, but tried to go cold turkey without success. Where is she at on the scale? All right, they're coming in 6, 7, 8, 6, 5, 6, 7, 6, 7. Thank you. Hello, everybody. 7, 6s, 8s, 5s, 9s, 8, 7, 4, 6, 8, 8, 7, 4, 8, 8, 4. Excellent. I think Jackie has to be up there in the green, right? Because she tried to stop. She went cold turkey and wasn't successful. So that shows us that she has some motivation. She just may not know how to do this in a way that's going to make her successful. So we could work with that, right? So thank you, everybody. I'm going to ask when our production crew gets a chance to see if I hit my 100% mark. Next slide, please. So we not only have to engage the woman, we have to engage her family. And that family is who she identifies as the family. I'm gonna just share a quick story. My sister has had 2 kids while using heroin. Um, and her support system, her family support system was her sister, myself, and my mother. We were the ones who supported her. So if you had asked her to get her family engaged, it would have been the 2 of us, as she would have identified as her family. So we really need to not try to look at family as the traditional family. Sometimes family looks different, or support looks different for women. So we need to find out when we're working with women who's important in their life, who are their support systems, who provide support. Sometimes it could be a friend, or I've had women say, my sister from another mother kind of thing. So it's not always family by blood that's your support system. Next slide, please. We also need to make sure we're using all of those evidence-based practices we've learned. When you're engaging somebody, you have to be using motivational interviewing. We also have to remember trauma-informed care. Um, One of the things that I was able to do from the beginning was think about, if I were in this person's shoes, how would I want to be treated? If I were sitting on the other side of that table, and would I want somebody to know, you know, I've been through a lot, and the person over on the other side may not know that. And so it's our job to try to find out what's going on with that person, but we need to make sure we're not causing more trauma in the process of doing this. Um, and we also need to give the person written information. One of the things that I'm gonna add to this is that we need to be culturally sensitive. So if you're seeing a lot of clients that English is not their first language, maybe we need written information in other languages. Next slide, please. We have to reduce the stigma. I, women are already beating themselves up. We do not need to add to that. And again, it goes back to the beginning, words matter. But one of the things I wanted to say was that everybody in your agency needs to be included in training about how language matters. Because if you don't have everybody in, sometimes that person who's at that front desk can set the tone for your agency. And if that person hasn't been trained, then it's not fair to her or him if they're out there and they're setting the tone. We need to make sure they know how to set that tone. I've been to some places where the staff were amazing, but that person at the front desk was a beast and was not kind, and it made me feel not welcome. And so even if I get to this great staff, I'm still gonna have that bad taste in my mouth. Next slide, please. So words matter, not going into it, but we don't want to use this terminology. I think it's important for us to remember that we need to be respectful. It doesn't mean that we need to try to make the mom or the woman use person first language. If she calls herself an addict, that's fine. But we are not to be calling her that terminology. Next slide, please. And it's just more of about words matter. um, my pet peeve, those people. That is one of my pet peeves. Those people are no different than us. So when you say those people, it sets it up like there's something unique about them. That they're they're people. Next slide. So what can we do? Basically, we give information. We help make sure that the woman is informed about any future complications or any future things. We have to be positive and encourage positive thinking. We need to be using our skills that are in our toolbox, the motivational interviewing, the trauma informed. We need to be discussing the benefits of emotional attachment to the infant. And we need to encourage activities for family bonding. Next slide, please. So here's how to help. We The assessment and the psychoeducation is not just a one-time thing, has to be ongoing. If when people meet goals, it's important to write in the assessment that they've met the goal or that they've done this, or if they change their minds about things. Um, it's important to make sure we're noting that in their file so that they can see movement, they can see progress. We need to do that warm handoff. When we're uh, doing a referral, it's not just enough to do a referral. We need to make sure that woman feels comfortable in going to whatever place we're doing a referral to. We need to also do referrals to pregnancy-related depression support groups and what other support groups that woman needs. We also need to do the patient activation around self-care. We need to be encouraging that woman to be doing self-care and not just be focused on everything else. Next slide. And this is one of my favorite sayings, and I think this says it all for what I need to say about engagement. People may not remember exactly what you did or what you said, but they will always remember how you made them feel. So make everybody feel like they're as important as the next person or as your boss, or as a president. Everybody should walk out of your space feeling like they're the most important person at that moment. Next slide. And here's some factors that encourage a woman to stay in treatment. They're the things that we know help. We being supportive, having supportive therapy. If we have on-site childcare or children's services, so she doesn't have to try to figure out where to leave her children when she comes to see you. Um, we have to also make sure we're getting significant others and their support and participation. Um, we also need to make sure they have confidence in our treatment process and outcome. So we need to be really working with the mom to help make this happen and to keep them into treatment. Next slide. And I'm going to turn it over to the amazing Tara.
That's quite the introduction there. Thanks, Pat. You know, I'm incredibly fond of that Maya Angelou quote as well. And while it's not an evidence-based practice, it's certainly something that resonates, that awareness that how we leave someone, you know, how we make them feel can have a huge impact on engagement and staying in recovery and services and treatment, and how important it is to remember the impact we can have in the engagement process. So I'm going to talk about evidence-based practices today. And next slide, please. So what do we mean by evidence-based? Well, we're talking here about interventions and strategies that have been researched and shown to be effective. So when we talk about research, we're talking about this intervention has been compared with another. So maybe it's something like contingency management, and there's been a research trial that has compared it to the effectiveness of motivational interviewing. And that research has been repeated and found over and over again is highly effective. So that's a key feature of evidence-based practices. Another aspect to think about is that evidence-based practices are specific to certain populations. Evidence base is been tested on or with rather a particular individual. So maybe adolescents or adults. So this particular approach, we learn that it's effective with women who have substance use disorders or folks with bipolar disorder, whatever the case may be. And the evidence base says that this service is effective with those people. And then there may be times when we use evidence-based practices with other populations that it hasn't been tested with. And we see efficacy, you know, in our offices or in the work, out in the field with those folks. We see that this is useful with them. And whether it's an evidence-based practice that hasn't been tested with that particular population, or it's just a practice you're doing in the office that hasn't been researched, those are practice-based expertise, something that we've seen work for folks. And those practices are just as important as the evidence-based practices I'm going to talk about today. They're equally important. I don't want to lose sight of that, even though my whole conversation, my whole presentation today is really focused on those evidence-based practices. Next slide. So the evidence-based practices we'll focus on are medication-assisted treatment, or MAT, motivational interviewing, some core behavioral approaches. These include cognitive behavioral therapy, dialectical behavioral therapy, or DBT, and contingency management. They're all rooted in a behavioral approach. We'll also talk about gender and trauma-informed approaches. We'll talk about peer support and a little bit about telehealth. So something to think about is that, as I said earlier, the approaches are tested with certain populations and show efficacy with those populations. For pregnant and parenting women, if you do a review of the literature and the research, ones that bubble to the top in terms of having had a fair amount of research for that particular population, for pregnant and parenting women with substance use disorders, the ones that bubble to the top are MAT, motivational interviewing, and contingency management. So those are the three core ones that have a fair amount of research with this particular population. And I'd like to invite you to go ahead and share with your colleagues in the chat the evidence-based practices you might be using, whether they're the ones here and especially ones that might not be listed here. Please go ahead and put those in the chat, share those with one another, feel free to chat away. I'm going to continue to move us on and share more information with you as you do that. Next slide. Medication-assisted treatment. I don't want to belabor the point. Deb referenced this earlier, but I do want to underscore the fact that if there is any doubt in anyone's mind at this point that medication-assisted treatment is a treatment of choice for pregnant women with opioid disorder, hopefully we dispel any reservations about that. It's highly endorsed. It's backed by the World Health Organization, by the American College of Obstetrics and Gynecology, by the Society of Maternal Fetal Medicine, and by the American Society of Addiction Medicine. So primary approach for women with opioid disorder. Next slide. So some things to think about when we're talking about MAT. First off, because we know it's so important for pregnant women to have the option to get on medication-assisted treatment, because we want sort of an even dose, and we want stability, because when you're obviously using drugs here and there from the street, you're going in this constant state of withdrawal, and that could be quite dangerous for her and for the fetus. So it's important that we're screening for pregnancy and that we can't forget that piece. It's something that sometimes can get lost in the mix. So during that early assessment engagement process, asking if there's any chance you could be pregnant, and talking with her about the fact, okay, maybe you don't want to use medication-assisted treatment now. If you were to get pregnant, let's have this conversation again. It might be more important to you at that point, and just opening up that door and letting her know to share with you if she does become pregnant, so you can have this conversation. And of course, when we're talking about MAT, we're talking about methadone and buprenorphine. Those are the ones that have been tested with pregnant women. There's and proven safe. There's less known about naltrexone and the safety of that. Some other things to think about, as I mentioned, the risk for withdrawal is important. So even while she's on methadone or buprenorphine, she can expect that there's going to be dosing adjustments. You know, her body's changing, and there's going to need to be increases in dose or frequency to prevent that withdrawal. One other factor to be really cognizant of is the coordination with providers. So across MAT providers, substance use treatment providers, recovery-focused folks, prenatal care providers, and labor and delivery providers, And embedded in some of that may need to be education. So some of those folks who on the medical side are working with her might not fully understand the importance of MAT and the safety of it. And so sometimes there needs to be a little bit of education there and advocacy for her. Next slide, please.
Hey, Tara, I'm actually going to reshare the slides because as you can see, there's some weird markings going on. So one moment while I switch screens and share them here. We'll see if that gets rid of it. Okay, that's looking better. Not sure what's going on. Let me get you to the next slide. And there you go.
All right, thank you. And so motivational interviewing, when we think about motivational interviewing, we're thinking about a lot of the core fundamental approaches in motivational interviewing, really across all of these evidence-based practices when we're working with pregnant and parenting women, where at its foundation, still using the evidence-based model, still using the principles and approaches, but there are some things to pay attention to for pregnant and parenting women, some nuances that might be a little different. And for motivational interviewing, you know, one thing to think about is the medical side of things. So of course you're using it with regard to substances, you know, those urges she may be talking with you about, that she's got this urge to use, and you're expressing, you know, empathy with that and validating that's, you know, a normal experience. The other piece is, of course, the prenatal care, the medical care, the prenatal vitamins, all the things that she's doing on that medical side. And motivational interviewing actually marries quite nicely with medical care. There's a lot of primary care practices that are starting to weave in motivational interviewing to activate patients in their own health care. And so using a little motivational interviewing to help activate her in her healthcare can be really helpful. For example, you may have a woman who says to you, you know, I missed my prenatal care appointment and I can't bring myself to reschedule it. I'm embarrassed. I feel ashamed. They're going to judge me. I just can't face them. I know that I should go, but I'm having a really hard time calling and making that appointment. So having a conversation with her about and really responding in an empathic way, you know, showing her that you understand that you're normalizing those emotions. Yeah, anyone in your situation would feel this way. You know, anyone might feel bad about missing that appointment, feel fearful of how people may perceive you when you go back to that prenatal care clinic. And then talking with her about sort of the creating that discrepancy between her goals and her values and her current behavior. One thing we want to be really careful of here is not to reinforce any of that shame. So when we create that discrepancy, sometimes in motivational interviewing, we might say something like, you know, I know it's really important to you to make sure you have a healthy pregnancy and a healthy delivery and a healthy baby. And how is, you know, skipping your prenatal care appointment going to help you with that? They can be tempting to try to create some discrepancy there in that way. And doing that, there's a good chance that sort of approach may trigger some shame. We don't want to trigger the shame because that's going to push her away and shut her down further. So what we might want to do in that situation is still invite into the room that vision she had for a healthy baby. You know, I remember you talking about how important it was to you that this is something you were going to do. You're going to make sure if you didn't do anything, you were going to have as healthy a baby as possible. That's really critical to you. And letting it sort of sit with her and then going on to talk about, I see how hard it is for you to make this next step and schedule that appointment and follow through. But those folks, whatever they think they're going to think, you know, it's not in your control. You can't control how they think. You can only control how you behave and how you think. And you'll know that you've made a decision in line with your values, in line with what's most important to you. So making that call, going to that appointment helps you stay in line with that vision you have for having a healthy baby, and trying to reconnect her to that vision. Talking about, well, let's make a call now. Do you want to make a call now? And then once she does make that call, really supporting that self-efficacy, reinforcing the fact that, look, you did this, you made that call, you pushed through all of that fear, and you were able to pick up that phone, make the call, assert yourself. You have this, you have what it takes to do this. Next slide. For cognitive behavioral therapy, you're still thinking about and working on helping her connect those thoughts and those feelings. So maybe she's had a conflict with a partner or family member, and now she's sort of ruminating. She's thinking about, oh, I shouldn't have said this. And it's causing all of this emotional turmoil. So you're doing that piece as part of good cognitive behavioral therapy, tracking those thoughts and connecting them to feelings. The nuance here is that there's a whole new layer of thoughts and feelings related to the pregnancy. And you want to invite those into the room, have conversations about those, and potentially do what I like to call taking them to court. So she has that thought of, these people at the clinic, they're going to judge me, they're going to say something mean to me, and asking her, how do you know? What is the evidence for that? How do you know that that's going to happen? So really trying to pull apart that thought. And there may very well be evidence for it. Maybe she's heard someone snicker or made a snide comment or something. And so she has that as a piece of evidence. And then the work becomes, how do you prepare if that happens again, or if it happens at all? How are you going to react? What are the supports you need around you? Do you bring someone with you? How are you going to respond? And if she's not unable to identify any justification for why she has that thought, then talking about how this is just a thought. We have lots of thoughts, that don't come to fruition. They just float around in our head. We think about lots of things, but they're not grounded in actual evidence that this is going to happen. And so you can put that thought at bay. In terms of dialectical behavioral therapy, DBT, Marsha Linehan developed this model for folks with borderline personality disorder early on. It's been augmented for use with lots and lots of populations, including folks with substance use disorders. She has a few key approaches for substance use. Obviously on the slide here, these are some of the core fundamental pieces of DBT. On top of that, there are some approaches like STOP, which is stop, take a breath, observe, and then proceed. This can be particularly helpful for people dealing with lots of emotions. And we know that pregnancy is a time when our emotions are all over the place. And then you layer on top of it all the struggles of early recovery. So working with her to pay attention to, all right, I'm starting to ruminate. I'm starting to have all of these worrisome thoughts. Let me stop, take a deep breath, pay attention to what's going on in my body, what's going on in my mind. And before I proceed, think about the next steps I wanna actually take, what I wanna say. Another method is the helicopter, taking a pull back and looking at the situation. Am I living in line? Am I making a decision that's in line with my values I can feel good about, regardless of what other people say, regardless of what the people at the clinic say. Burning bridges, we know that in substance use, we do burn bridges. That drive to get the next hit is leading us to make poor decisions sometimes that lead to burnt bridges with family and friends. Well, Marsha Linehan, she talks about intentionally burning bridges. So this is where you're severing ties with people, places, and things that would be triggers. And then alternate rebellion. So sometimes there's this sense of excitement that comes from using. And she talks about, finding an alternative, finding something to replace that excitement, that sense of rebellion, maybe getting a tattoo, getting a motorcycle, something that feels rebellious to the individual to substitute that piece. Next slide, please. With contingency management, there are a couple of factors I just want to bring up here. So we know at the core foundational approach to contingency management, there's a target behavior that we're trying to reinforce. So maybe it's abstinence. So every time she has a negative urine screen, she's given a gift card. Or if she attends group, then she's given a gift card. Or they're banking points. I have a negative urine screen and I bank my points. I get a point every time that happens. I bank my points and then I can turn in my points for a large reward. So we want to think about, for pregnant and parenting women, we want to think about what those target behaviors are and what the rewards are. They might be different. You might want to add on something like prenatal care, that you get points for attending the prenatal care appointment, or you get the reward for attending the prenatal care appointment, not just the negative urine screen. And then what those rewards are also important to think about. So for pregnant and parenting women, they're thinking about potentially, what do I need to get in place for this child? So there's lots and lots of things babies need, and it may be very motivating to have the ability to be rewarded with those things, right? So baby clothes and the baby bathtub and the big reward that she banks all her points for, maybe a car seat, things like that. One cautionary piece I want to say is that to be really intentional about those rewards. And if there are baby items that are given out philanthropically, that are just sort of given to women in need through your organization, don't use those as the reward for the behavior you're trying to increase. You end up potentially diminishing the effect of that reward if you can get it in some other means through the program as a sort of donation or something like that. Next slide, please. Evidence-based trauma. There's a listing here of some evidence-based trauma treatment approaches. These are approaches for children who've experienced trauma, and they're approaches that are used with parents, caregivers, and their children. And it's important for us to remember, while we may be working with the parent, they may have other children, and those children may have been on this path of recovery with their mom and have had experiences that are traumatic, as may have the mom. And so this is a really great list of resources, some highly esteemed trauma treatments for kids. And the work really is done directly with the parent as well. The first three are probably the most popular. And you'll be getting a copy of the slides. You'll be able to look through those. There's links. You can read more about them and get more familiar with them. Next slide. And then some additional resources. So we've got a list, not exhaustive, just a sampling of some curricula that are focused on women and substance use, so gender focused for women with substance use disorders, and then co-occurring, so folks who have substance use and trauma. So what are some of the curricula there listed in the center column? And then lastly, trauma-specific interventions for women. The slide before were trauma-specific for children. Next slide. Peer support, also really, really crucial and important component of recovery. It can help women stay engaged, make them feel like they're not alone. They have this sense that someone else has been through it too, that there's hope in that. They can see a path forward, that if they can do it, I can do it too. folks with lived experience have lots of experience navigating the system. They can support and teach the woman about different aspects of the system, connect them with social supports, and you know, maybe even think through reconnecting with some of those natural supports, those family and friends, and what that might be like. Next slide, please. Technologies and telehealth. Well, boy, COVID has taught us a lot about telehealth and how useful it can be. And lots of organizations are continuing to use those telehealth practices, even though things are getting back to the new normal. So particularly for women who have trouble getting back to the clinic, or for folks in rural settings, lots of organizations are continuing to maintain some sort of hybrid where they offer telehealth. It can be really useful for those populations, of course. And then there's lots of different apps out there these days, phone apps, where folks can get on, download a free app and get lots of support and learning and guidance through those apps. So there are a few of them like Nomo or Sober Grid help you keep track of your sober days, connect with social networks. Recovery Box helps you work through the 12 steps. We Connect gives daily reminders. You know, you can set up reminders to call your sponsor, to go to meetings, check in at meetings. Lots of great apps out there. I invite you all to put in the chat if you have any apps that you recommend, you've seen people use and benefit from. Please share it with your colleagues in the chat. And next slide, please. Case management. Lastly, I just want to say a couple of quick things about case management. It's an opportunity to support that self-efficacy and self-determination. It's so important to build this for women in particular. And some of the ways we can do that during the case management process is to think about which pieces we should do for her. She's so overwhelmed. Things are so chaotic right now. She's not going to be able to make this phone call. Let me make the phone call for her. Times when we want to do it with her, like the example I gave earlier where, okay, let's make that phone call right now. She's making the call, but I'm going to sit here and be a support to her as she calls the clinic and schedules that prenatal care appointment. Or times when we want to give her the opportunity to do this piece of case management work. You're going to make the phone call, and then I'm going to really reinforce that and underscore her ability to do this on her own. See, you know, you have been making these appointments. You've been scheduling all of these appointments with people. You can do this for yourself and you can do it for your child. You've got the skills, because oftentimes we don't see these in ourselves and we have to be reminded over and over and over again. Next slide, please. Lastly, Deb will talk a little bit more about the family piece, but one reminder with case management is that you're now thinking about the whole family, not just linkages to services and supports for her, but also to services and supports that her kids might need. And in particular, when you're thinking about things like housing, you're also paying attention to the proximity of that house to school. So if she's getting into new housing, you know, is there a grocery store nearby? Is there a laundromat available? Parks and playgrounds for the kids? You know, is the apartment de-leaded? All of these really important pieces to widen the scope and to think about the family as well. Next slide, please. And more on family-centered practices for Deb to carry on.
Great, thank you. And it was great I'm loving this presentation. I'm loving all of the chats that are going on in the box. I am going to just walk you through some of these slides and highlight a couple of different pieces. I think I mentioned at the beginning, we could talk about this content for over a week. So I'll just draw your attention to a few different things and turn it over to Pat to talk about some recovery supports. Emily, go ahead and go to the next slide. Obviously, a new baby affects all aspects of a woman's life. It is not just, all right, so now, I go, now I'm back and I'm ready to just keep on moving on. I'm working with a woman in Bakersfield right now, and she's just like, oh, yep, I'm going to go into labor. I'll have the baby and I'll be right back. And it's like, I don't quite think so, particularly for those of us who have more than one child. It just gets everything becomes a new way of doing things. The pictures on here are a mobile, because you can think of a family like a mobile. Edith Schaefer has a great analogy like that. So each piece spins individually, and the whole thing has to balance and stay together. So one thing changes and the whole thing has to find a new way of doing things too. Go ahead and go to the next slide. So I really like the approach of treating postpartum as a fourth trimester and building that into all of the services and a woman's thinking about what she's doing. Because after the baby is born, her body is going through changes. She has some work to do in terms of her own health and wellness, and building that, doing some of the pieces around nesting, adjusting the family. It is a point where she is very vulnerable to a return to substance use. And unless she has active recovery planning built in, she's probably going to return to some level of ambivalence, because I was ready to do it, while the baby is inside of me, but I don't really know all of the other feelings and reasons that substance use worked as a coping skill. My motivation has to change. So, this is a time to increase check-ins, building in home visiting if you can, all of those different things. We now know perinatal mood disorders is a real significant impact for a lot of different people. So paying attention to that, paying attention to the family changes and stressors that are happening, access to contraception. So thinking from just, the kind of OBGYN side of the health, if we build in contraception in that fourth trimester for those people who want it, a lot of times it's very difficult to access. So building that into the system and increasing the services to not reducing them. We're going to just leave her be because she can't come to the program. No, that doesn't really work. How are we going to build in ongoing support and check-ins for her while she is going through some of the potentially challenging things that she may be going through? Go ahead and go to the next slide. So at delivery, ideally, and we've seen some of this already in the chat, I think Casey was talking about this. Ideally, all of the women that you are working with have well-planned, collaborative, and supportive birth plans, working with hospitals and prenatal care providers and pediatricians who have been trained and are understanding around substance use disorders, neonatal abstinence syndrome, if they have an OUD, and anybody who's involved with child welfare is also on board and seeing the great work that she's doing, assuming, of course, that she is in that space. That is not always the case, right? So working towards and building your collaboration and your integrated team so that you know where it's going to work best, but also preparing her for possible stigma, discrimination, micro and macro aggressions at the hospital and with care providers, so that what she doesn't do is feel their shame, own it, and then penalize herself, as Tara was talking about. Helping people be prepared with what to expect from child welfare is also really important. One of the other things I often will talk about is the importance of grief counseling. What to expect in terms of her health, her infant possible health needs, if she has been using opioids or alcohol, being aware of those pieces, but also, there are some, babies, if she was using marijuana or stimulants, there are some other potential health risks or things, and how to, really take care of their baby and take care of themselves. Feeding, there's a lot of misinformation about who can breastfeed. So making sure that if breastfeeding is an option, that she has that, and support and plan if the baby can't come home with her. So how she's going to handle that, as well as, if the baby can go home with her. So preparation for delivery. Emily, go ahead and go to the next slide. and just keep going. This slide has a resource. A friend of mine from Massachusetts developed it's called the Journey Recovery Project. It has great resources to help. It's a peer-based resource that includes stories and videos and tools to help women who are entering recovery and sort of reinforce that they're not alone. So I'll encourage you all to take a look at that and think about what other resources and apps you might offer. Go ahead and go to the next slide. Of course, you want to be promoting secure attachment and helping people be able to hold, touch, feed, skin to skin, the importance of talking with babies. This is true for the mom. This is also true for other family members who may be involved with her, and making sure, because depending on what the experiences that she's had, she may need really hands-on coaching as well as supports to build that relationship. It also be that she's completely got it with an infant, but then when the children get a little bit older, she ends up finding more difficulty with parenting, depending on some of her own trauma experiences as a child. But of course, we want to be promoting and acknowledging what she's doing well in terms of secure attachment. Go ahead and go to the next slide. Separations and reunification are stressful for both parents and children. That's really important. And again, we really want to be stepping up, going back to that basket, how we can be creating the rings that really help support that family. Go ahead and go to the next slide. And I love this, but we'll just keep going past it. And, of course, why family-centered care is important for women. I'm just going to say something in this first bullet. Connections tend to be very high priorities for women. So a friend of mine, Francine Feinberg, actually, she was the director for MetaHouse in your area for a long time. So many of you may know her. One of the things that she used to say as anecdotal evidence is that women keep coming back to a program if you like them. Men keep coming back if you feel like they're getting something out of it. So for women, that connection inside the program and then also in the other services and the other resources and in her life becomes particularly important. Go ahead and go to the next slide. And past this one, we all know that families are more than just families are kind of where everything comes back to. Pat already talked about identifying and engaging family members. We tend to immediately think of the immediate family. Oftentimes women will benefit from thinking of a broader context in terms of family, of that person who was a neighbor when they were growing up, who's always been there for them. And they also often will need help rebuilding and engaging family members. And, of course, with any releases of information, they may ask you to make a call to let somebody know that they're doing really well. And it would be great if they could come to a family picnic, because otherwise they feel like it's one more time that they are a burden for their family. Go ahead and go to the next slide. And so I only want to say a couple different things about domestic violence, because it is important when we're paying attention to families to pay attention to the high correlation between domestic violence and women's substance use disorders. So if you recall in the example that Pat gave at the beginning, where the person was saying she wanted custody of her children, she had some goals related to not using substances, but she also says, but I went out with my boyfriend and we used substances, last week. It is possible that she's actually in a relationship where she's coerced or controlled through that substance use. And I'm not going to go through the statistics, but it's actually pretty alarming how many of the women who we see have somebody who is either using their substance use disorder as a way of controlling them and threatening them, and or who is using substances as a way of pressuring or controlling them. So always make sure to check in terms of the safety of people and coming up with safety plans, and only engaging people as they want to be engaged, and really keeping an eye out for that coercion, because it might look like she's making a choice that she may actually not be making a choice. And go ahead and go past the next slide. and go ahead and pass this one in terms of factors affecting families. So family-centered services, there's lots of different kinds of programs and groups, again, going to that basket that we can be offering. We don't have to do it all on our own. Those of you who've built collaborations with child welfare, with parenting agencies, with other community agencies, with infant mental health agencies, bringing together mental health and substance use or behavioral health providers and healthcare providers, but thinking through all of the different pieces that you really want to be able to offer, including this last piece of holidays, recreation, and leisure, because families do need to be able to have fun together. And we're going to go past the last slide, which talks about children's services, because we also want to help them engage in services. And part of what women often need related to families is really help to create some structure and stability. Somebody, I think it was Tara, was talking about also it can get a little bit boring. That's true too. Learning how to be bored, and I still am learning how to be bored, or healthy ways to have that kind of excitement in a way that you're also creating that sense of safety and nurturing and adventure for families and children. And with that, I'm going to turn it over to Pat to spend a couple of moments talking about the recovery supports.
And it will be a couple of moments because we do want to get you out of here on time. So I'm sure everybody knows about recovery supports. Hope. We have to keep hope. Sometimes we have to hold on to the hope until the woman is there at that point to have hope. But hope is important in helping women to recover. Next slide. Wellness. This is really about making sure we are paying attention to the entire person, the woman and her family. Everything is going to impact other things. So we need to just make sure we are paying attention to the entire person and not just one part of her. Next slide. We can't focus on the parents' recovery without addressing the needs of the children. And I know I'm saying it, I'm preaching to the choir, but we also have to remember to pay attention to the needs of the children when we're working with the parent. That not only helps the child, but it will help that mom learn how to pay attention to the needs of her children by you modeling that. Next slide, please. We got to have a family focus. I just put some bubbles together, thought this was a great way to break it out. So, look at this and, some categories go across all. Like I think trauma should be across all categories. Next slide, please. And I'm going to turn it over to Deb to let her take us home.
Great, thank you. And I'm going to go ahead and have you just go to the very last slide on the upcoming Learning Collaborative, just so that everybody is aware of this. We're going to also be putting the links in here, and you will also get it in an email. If you could scroll past this slide all the way to the one that says Upcoming Learning Collaborative. So we have planned with Jean a learning collaborative. It's going to be 5 one-hour sessions for people who are really passionate, interested, and engaged in working with pregnant postpartum women. We're drawing some on an approach that we used in the WASLI program, and we'll give you the opportunity to reflect on experiences and talk about some of the current trends, innovations, opportunities that are happening. And if you are interested, there is an application to participate because we are going to limit the number of participants. It won't take you very long. And it also asks you about what topics you're most interested in. Emily will also send you out the evaluation form. And I want to thank our tech team, thank our other speakers, thank Jean, and thank all of you. I hope you all have wonderful, wonderful days. We all have been on the theme of language for some reason today. So just to the closing quote slide says, words are important. If you want to care for something, you call it a flower. If you want to kill something, you call it a weed. So I'll close with that, and I hope you all have wonderful days. And that slide's an accident. And happy Juneteenth.